Good morning and welcome to Craig Hospital U webinars. I'm your host, Brigitte Trace, Respiratory Therapist, and today I will be discussing respiratory care and how it relates to the acute rehab setting, focusing specifically on spinal cord and traumatic brain injuries. We will begin today by discussing this presentation's outline and objectives. We will take a look at Craig Hospital and the patients we treat. We will then discuss care of these patients prior to admission to acute rehab. Next, we will move to the management strategies of the respiratory system for patients with high cervical spine and brain injuries. We will then conclude with discharge planning, returning to home, and complications post-acute rehab. At the end of this presentation, attendees will have a better understanding of the different levels of injuries that require respiratory care, have a better grasp of complications that occur prior to the rehab setting and challenges that shape respiratory care goals. Be introduced to a variety of respiratory techniques used in inpatient acute rehab, and be taken through discharge planning for a respiratory patient, common complications after discharge, and the importance of post-acute rehab care for preventing further complications. My name is Brigitte Trace, and I've been a respiratory therapist for 12 years. My journey to respiratory therapy is a bit convoluted. When I was young, I had no idea what I wanted to be when I grew up. In high school, I saw a video about wheelchair basketball, and it really resonated with me, but I had no idea what someone could do to work with this population. I'm 5'3", so I certainly don't play basketball. Instead, I received a Bachelor's of Fine Arts and started my career working for museums, art galleries, and in public relations. While working in PR for National Jewish Health, which is a respiratory hospital, I was introduced to respiratory care. So I decided to go back to school and complete a degree in respiratory therapy. This is when I discovered Craig Hospital, and suddenly that childhood memory of wheelchair basketball came roaring back to me, and I knew I had found my calling. After working for many years at Craig as a staff therapist, and after watching my own father struggle with severe pulmonary disease, I saw a need that was not being met in the area of discharge planning for patients with complex respiratory needs. This role seemed to be a natural fit for me and has allowed me to combine my past experiences in public relations and the art world to come up with creative solutions for difficult discharges. If some of you are not familiar with us, Craig Hospital is a world-renowned acute rehabilitation hospital located in Englewood, Colorado, which is just south of Denver. We exclusively treat traumatic spinal cord and brain injuries. We are a nonprofit facility with 93 inpatient beds, and we offer unique in- and outpatient services, including cutting-edge research. Along with treatment and rehabilitation, our role is to help patients redefine what is possible despite these life-changing injuries. Next, we're going to come to our first poll question. We'll begin again in about 15 seconds. Craig treats patients from all over the country, sometimes even the world. This has resulted in an amazing culture and has created a rich and immense network of love and support for our patients. In fact, once patients are discharged, we no longer refer to them as patients. They are alumni. Each patient is assigned an interdisciplinary team that stays with them throughout the entire inpatient experience. The patient and their families are a critical part of this team. The goal is to help them achieve as much independence as possible. They are supported by a variety of staff who teach them the skills and connect them with the resources they need to transition back into their home and community. Craig offers a unique rehab experience. Listed here are just a handful of our out-of-the-box services and therapies. I especially would like to draw attention to the services highlighted in red. We provide one-on-one behavioral attendance for many brain-injured patients. Our patients are never physically restrained. This process helps lower overt stimulation and allows the brain to concentrate on healing. We offer community re-entry programs to help you if you would like to pursue a new career. We own an apartment building next to the hospital where out-of-state families stay free for the first 30 days. We have a strong education and training program to prepare patients to return to home. When patients discharge with critical respiratory equipment, such as a ventilator or trach, their families and caregivers are virtual mini respiratory therapists by the time they leave us. Our engineering department can adapt just about anything to get patients back to what they love doing. Our seating and mobility program gets our patients back to independence. Our soft landing program allows staff to sometimes travel home with patients to ensure a safe transition. And our event weaning program is hard to beat. We have an amazing track record of liberating patients from mechanical ventilation. Our patient outcomes are higher than the national average for other similar facilities, including higher return to work and school rates, return to community rates, and independence scores. Craig is a nationally recognized hospital and has been ranked in the top 10 rehabilitation hospitals in the nation for 30 consecutive years by U.S. and World Report. Craig is voted by its employees as a top workplace by the Denver Post and was ranked in the top 150 places to work in healthcare by Becker's Healthcare in 2014. Now I would like to move on to discuss today's main topic, which is respiratory care in the acute rehab setting, with a focus on traumatic brain and spinal cord injury. So who is the typical Craig respiratory patient? We often see patients with high cervical spine injuries, with C5 and above being the most complicated, because that level will more than likely impair the respiratory system. We also see traumatic brain injuries that affect the swallow and gag reflex, and injuries that involve comorbidities such as COPD and asthma, chest wall trauma, restrictive lung process, patients with cardiac issues that affect the cardiopulmonary system, and people with sleep issues. Admission to an acute rehab setting early in the recovery process can be a critical step for many patients. Traditional hospital settings have a different focus. They're concentrating on stabilization. During this time period, few patients get a full exploration of key areas such as, does their respiratory system function independently? Have their swallow and gag reflexes been evaluated by a speech pathologist? Are they able to vocalize? Their chest x-rays are generally quite poor at this stage, and they are in need of specialized pulmonary hygiene and airway clearance therapies. For mechanically vented patients, delayed admission to a specialized program can lead to less than ideal vent management techniques, contributing to pneumonias and atelectasis, sensations of air hunger, and even a false sense that a patient is weaning off vent support. This occurs when a patient, who may not actually have a functional diaphragm, is placed on a ventilator mode that mimics a spontaneous respiratory drive. I'd like to draw attention to the box up at the left corner. In the right-hand corner, this is a great example of a vent mode that is spontaneous in nature, but heavily supported by pressure support to create a much larger breath than the patient might be capable of, in combination with a setting called the trigger, which allows the patient to signal to the vent that they are taking a breath. The trigger in this example is set too low. The patient only has to generate 0.5 liters per minute of negative inspiratory flow. This can easily give a false impression that the patient is doing the work. Also, trach tube stomas are sometimes not managed well, and turning schedules are poorly adhered to, resulting in skin wounds. When a patient is admitted to acute rehab, the goals differ vastly from other settings. We work on their health and their rehab simultaneously for the best outcomes. We want to improve airway clearance and gas exchange. We will evaluate the function of the diaphragm and begin the weaning process if a patient is able. We will continue to work towards liberating the patient from mechanical ventilation while they are attending therapies and classes. We don't wait until they are off vent before rehab can begin. We work with speech to conduct swallow evaluations and trach cuff deflations so a patient can communicate. Our goal is eventual removal of the trach tube. If a patient is unable to wean and is ventilator dependent, we begin to train the patient and their families how to manage a ventilator and tracheostomy early in the rehab process. We educate all of our patients on how to keep their pulmonary system health throughout their lifetime. We want to achieve the highest level of health and independence for our patients. We want our patients to live productive lives despite their injuries. We want patients to return home to their friends and families. We extensively train the patients and their families to manage critical respiratory equipment in the home if needed. Many of our families will know more about the ventilators and trach tubes than their home care respiratory therapists and nurses, especially concerning the tricks of the trade when it comes to spinal cord injury. Our out-of-patient program follows patients after they leave Craig and is also offered to patients who do not have the opportunity to come to Craig with their initial injury. Next, I would like to talk about how a spinal cord or brain injury can affect the respiratory system. It's important to note that many of our patients are young, healthy people without prior respiratory disease or any health issues for that matter. So what actually happens to the respiratory system in cervical spinal injuries? If the injury is high enough, you may have complete respiratory failure and arrest. Lower cervical injuries can result in respiratory insufficiency and distress. This can lead to immediate intubation and mechanical ventilation. Later, the patient will most likely receive a tracheostomy. Use of an artificial airway and the usual lack of a swallow or gag reflex often leads to pneumonia. Central nervous system changes and persistent irritation in the airway and lungs causes hyperproduction of secretions. Loss of a cough effort to remove these secretions further complicates that situation, leading again to risks for pneumonia and poor gas exchange. Changes in surfactant production caused by CNS changes and prolonged mechanical ventilation and recumbent positions lead to atelectasis. Finally, loss of movement leads to muscle atrophy and weakness. Here's your second poll question. Everyone answered that question correctly. We'll begin again in 30 seconds. So how do we treat the respiratory system of a cervical injured patient? Many pulmonologists have published large bodies of work on this subject matter, including Craig Hospital. However, I think I've found the best explanation of these theories and techniques that can be described in layman's terms or in terms for healthcare providers that are not respiratory therapists or pulmonary experts. I've found the best example published by the Consortium of Spinal Cord Medicine entitled Respiratory Management Following Spinal Cord Injury, a clinical practice guideline for healthcare professionals. I provided the link, and you are welcome to read this publication. It's quite lengthy, but in a nutshell, it's all about expansion therapy and what a pulmonologist would refer to as diligent pulmonary toilet, or flushing and removal of secretions from the airway. The theories behind mechanical ventilation in these patients involves providing very consistent and larger than traditional lung volumes to combat atelectasis, recruit collapsed alveoli, and mobilize secretions. Using higher tidal volumes boosts surfactant production, recruits airways, helps reduce additional collapse, reduces the sensation of air hunger, and helps to mobilize secretions. We generally will use targeted volume control modes on the ventilator to provide consistent volumes and to avoid de-recruitment of the airways. We focus heavily on pulmonary hygiene and utilize specialized equipment to aid in the removal of secretions. Remember, our goal is to reduce atelectasis and improve gas exchange. Providing larger lung volumes means we are often hyperventilating the patient. Therefore, managing the patient's arterial blood gas values will be extremely important, namely their PaCO2 levels. So just a quick refresher. Changes in PaCO2 levels can affect tissue perfusion and metabolism. Too much or too little CO2 changes your hemoglobin's affinity for oxygen. So to our nurses out there, does anyone remember the oxygen dissociation curve, which I've pictured here on the right? This curve plots the point in which at any given PaCO2, your hemoglobin becomes 50% saturated with oxygen. This is called the P50. So in traditional settings, ventilating with smaller tidal volumes can lead to hypoventilation and an increase in PaCO2. This decreases hemoglobin's affinity for oxygen. So think about it like this. You have a bunch of O2 molecules hanging out at the bus stop, but no one wants to get on the bus, or hemoglobin in this case. This leads to poor tissue perfusion. In addition, an increase in CO2 increases the respiratory drive in the brain. However, a high cervical spinal cord injury who is unable to increase their respiratory rate or depth of breath because they don't have a spontaneous drive will feel severely air hunger and severe discomfort. Utilizing larger volumes, such as we do here at Craig, when mechanically ventilating a patient, can lead to hyperventilation, meaning I will be blowing off all of the CO2. This can lead to respiratory alkalosis, which increases hemoglobin's affinity to oxygen. So now there's a bunch of O2 molecules on the bus, but nobody wants to get off the bus, not allowing the O2 molecules to oxygenate the tissues. So my personal experience with this is someone's pulse oximetry can look terrific, but when you draw their blood gas, you actually can see that your PaO levels in the blood system are quite low. So how do respiratory therapists manage CO2 values? If hyperventilating patients, if we are using the gold standard for managing the spinal cord injury, which is giving these higher tidal volumes, so how do we manage their CO2 levels if we use larger tidal volumes? I'm not going to change my respiratory rate to affect my minute ventilation because I want to simulate a normal breathing pattern. So what do? I use mechanical dead space in the ventilator circuit. I add length to my circuit by adding segments of tubing until I reach a normal end tidal CO2 value. It's the paper bag over the mouth concept in hyperventilation. I want to retrap the CO2 from the exhaled breath, leaving it in the circuit to be taken up with the next inhaled breath. Next, we will talk about what pulmonologists refer to as pulmonary toilet. I know this is an odd term, but I think it's a great way to describe what needs to happen. We really want to flush the pulmonary system clean out secretions, and improve atelectasis that are interfering with gas exchange. When treating the pulmonary system, we want to use an arsenal of equipment. In traditional hospital settings, or even other rehab or long-term care facilities, they may only have access to a simple nebulizer and tracheal suction. But what you really need is a quiver of tools. This slide pictures just a handful of the devices a respiratory therapist can utilize to help with airway clearance. We have tools for expansion therapy, percussion therapy to mobilize secretions, tools to aid in suction and improve humidification, and tools to build strength. All of this is paramount in treating the lungs of someone without the ability to clear their own airway. All of these techniques are getting us ready for the next step, weaning patients from the ventilator. Without clear, well-expanded lungs, liberation from the vent will be nearly impossible. It's important to understand that within 12 hours of a cervical injury, the diaphragm can begin to atrophy. The diaphragm is the marathon runner of the body. When the diaphragm atrophies, its long twitching muscle fibers begin to act like fast twitching. So the marathon runner suddenly becomes a sprinter, capable of only short actions. Our job is to turn the sprinter back into a marathon runner. Just like training for a marathon, you begin with interval training, removing the patient from support for a period of time followed by a rest period, gradually increasing time off the ventilator with shorter rest periods until the patient is liberated from mechanical ventilation. You would never begin training for a marathon by running 16 miles on your first day. Many traditional settings will often utilize a sink or swim technique, placing a patient in a supported yet spontaneous breathing vent mode and have the patient work the majority of the day. This can result in extreme fatigue. Also, sometimes the parameters of the vent are set in a way to provide too much help, falsely giving the impression that a patient is doing the work on their own. And I demonstrated this a few slides prior. Then, when removal from the vent is attempted, the patient fails. However, the sad reality is there are some people who will never be able to wean from support. If liberation is impossible, we train our patients, their families, and caregivers to manage these life support systems in the home. Our families are virtual mini respiratory therapists by the time they leave Craig, often having a better grasp of mechanical ventilation than most other healthcare providers. The good news is, invention of the diaphragmatic pacer, or DPS, has created new possibilities for ventilator-dependent individuals. By artificially stimulating the diaphragm muscle with electrodes, we can generate a muscle contraction that in turn generates a breath. Electrodes and lead wires are implanted on the diaphragm. The wires run to the outside of the body and are hooked up to an external box that allows us to control the breath. A frequency is set. This establishes the respiratory rate. Then an amplitude is set. The amplitude is the amount of power or current sent through the electrode that contracts the muscle, allowing you to change the size of the breath. The DPS system allows patients to be off the ventilator for all or most of the day. But at Craig, we recommend patients rest on the ventilator at night to provide those larger, fuller breaths and reduce the risk for atelectasis. Traumatic brain injuries can offer unique respiratory challenges of their own. When the injury affects the part of the brain that controls swallow, gag, and protecting one's airway, risk for aspiration becomes a real concern. Aspiration often leads to pneumonia. These patients generally need a tracheostomy tube to allow access to the lungs for suction. Also, we often find that the mechanisms that allow someone to generate a spontaneous cough are also interrupted. The patient may feel or know they need to cough. However, the injury to the brain will not allow this to occur unless the gag reflex is stimulated. So clearing their own airway on demand becomes difficult or impossible. Craig's respiratory, speech, occupational therapy, and physical therapy departments will often work together in sessions we call co-treats. We attempt speaking valve and capping trials together. We often meet the speech therapist in the patient's room to deflate the trach cuff for vocalization and eating trials. This can also occur when the patient's on the ventilator as well. Speech and occupational therapy will set the patients up with communication devices if they are nonverbal. We work together, bringing different aspects of different disciplines together to work on the same problem for optimal outcomes. Managing a tracheostomy can be difficult because it changes the physiology of the airway, leading to an increase in secretion production because the mucosa is stimulated by a foreign body in the airway. Thick, hard to remove secretions due to suboptimal humidification. It also offers a path for opportunistic pathogens to enter the lungs. A loss of anatomical PEEP to keep the alveoli of the lungs open because the air pressure in the chest cavity is difficult to maintain. There's no lid on the container, so to speak. Trach tubes generally increase the length of hospital stays. And discharging to home with a trach imposes enormous stress on the family. And communication between caregivers and patients is impaired if the patient is unable to vocalize. Therefore, managing the initial challenges that the tracheostomy tubes present is an important step to stabilizing the patient's health. We work tirelessly to get them swallowing again, achieve an effective cough, eating, talking, and protecting their own airways. Deflating the trach tube cuff, either permanently or even for short trials, not only gives the airway tissues a break from the pressure of the balloon, but it also allows us to cap the trach tube. Capping the trach tube is important because it produces glottic pressure and exposes the lower pharyngeal nerves to pressure and stimulation. This allows for sensation below the cuff of the tube and creates subglottic pressure. This in turn allows the vocal cords to work properly and allows the breath to stay in the chest cavity, again putting a lid on the can. The full lung volume helps bolster the cough effort and reduces the risk of aspiration. This slide demonstrates this concept. Many years ago, I attended a conference with the speech therapist. Dr. Roxanne Diaz-Gross demonstrated how lung volumes can affect the closure of our vocal cords. The cells below the cords are like little springs. The air in the lungs loads the springs and helps with closure of the cords. An uncapped trach tube allows some of this pressure to escape, resulting in suboptimal closure. By capping the trach tube or placing a speaking valve, we can maintain air pressure in the airways, which helps to load these little spring-like cells, allowing for a tighter closure of the cords. This helps guard against aspiration and allows for vocalization. And it goes without saying that the ability for patients and staff and family to communicate is a basic right. It's necessary for safer, more effective care and ultimately a better quality of life. If a patient's condition does not allow for use of a speaking valve or cap, maintaining diligent pulmonary hygiene will be a priority. And alternate communication techniques and devices will be necessary. Sleep is another large issue for folks with spine and traumatic brain injury. These injuries often affect a person's sleep aperture. In spinal cord injury, the muscles that overcome the weight of the body and soft tissue in the neck or a tongue falling back into the airway are now much weaker, resulting in obstructive sleep apnea. CNS changes, whether due to brain or spinal injury, affect the mechanisms of sleep. So we often see central sleep apnea as well. And something most of us wouldn't think about, we often correct upper airway obstructions subconsciously by rolling over on our sides or stomach during sleep. But a quadriplegic or traumatic brain injury patient are unable to do this on their own. Also, CPAP can be challenging for an individual who is unable to adjust a mask on their own. Working with the patients, doing mask desensitization and CPAP trials during the day helps us get patients ready to trial PAP therapy during the night. As patients improve and begin to plan for discharge, it's important for the respiratory therapists and other medical staff to talk with the patients about long-term strategies and goals. It's important for them to understand that maintaining respiratory health should be a priority. After all, respiratory infection is the #1 killer of people with high cervical spinal cord injuries after they leave rehab. And it's important to discuss some of the complications people might run into down the line. Weight gain is very common. After I see people leave Craig, they often come back maybe a year later and the weight gain can be significant. Food is a source of joy for many people, but the inability to exercise leads to weight gain, which leads to stress on the muscles of respiration. If people suffered co-injuries from the original accident, this can cause issues later in life. Another big one is lifestyle choices. Remember, the average patient at Craig is a young, healthy individual, but they sometimes have risk-taker personalities. And these attributes don't necessarily stop simply because they have an injury. They might engage in smoking, drug use, or other addictions that can affect their long-term health. And then aging with these injuries is probably the biggest concern as folks move through their lives. Now we have poll question number 3. After discharge, although they have weaned from mechanical ventilation, some patients are still very weak and can fatigue throughout the day. After removal of the trach tube, invasive interventions are no longer possible. However, non-invasive mechanical ventilation, where a patient uses a mask instead of a breathing tube, can provide support when respiratory insufficiency is an issue. This strategy is particularly useful for individuals aging with spinal cord injury. We all lose lung capacity as we age. So as one might imagine, this impacts spinal cord injured patients tenfold. In the past, people sometimes ended up back on a ventilator with a trach tube for sleep due to this aging process. Also, excessive weight gain can cause a similar scenario. But with non-invasive ventilation, it's more like wearing a CPAP mask that provides positive pressure and breath support. Mouthpiece ventilation is also an excellent tool to aid in reducing fatigue and atelectasis associated with respiratory insufficiency and aging. This device provides an on-demand vent-assisted breath delivered through a mouthpiece. The patient simply takes a breath off the ventilator as needed to reduce fatigue, bolster breath support, and open the lungs. It can also be used to beef up the lung volumes and produce a more forceful cough, and beef up the volumes for a stronger voice when people are engaging in long conversations with others. One of the things that I feel is particularly unique to Rehab is the level of discharge planning we do. We want to ensure our patients are set up for success. I view this as our ultimate goal. We extensively train our patients and their families to manage their respiratory health after discharge, no matter what that looks like. Often that means living on a ventilator or with a trach tube for life. We ensure our patients have the right equipment, even if that means it's donated or a foundation picks up the tab. I find that across the nation, the philanthropy associated with Craig and places like Craig is overwhelmingly committed to the long-term outcomes of this patient population. Craig also has a soft landing program where and when possible, we sometimes accompany a patient home to coordinate delivery of equipment and setup. Or we allow the patient to move over to our outpatient family housing apartments to live independently for a few weeks, but still have access to Craig's teams for help, advice, and to work out the bugs. This helps the patient's families fine-tune their caregiving skills before they are on their own at home. My favorite part of the job is the ending. People come to us broken in mind, body, and spirit, but they leave with a new sense of possibility, a community, and the love of an entire culture. I often tell people, Craig isn't just a job for me, it's my life cause. So in summary, I hope that what you've learned today is that respiratory care for spinal cord and traumatic brain is unique within the field of rehabilitation. These injuries will require special interventions and tools. Craig's approach stands as a gold standard for these injuries. And ultimately, our goal is to return people to their lives despite these life-altering injuries. I would like to thank you for attending this U webinar, and I hope you have found this presentation informative and helpful. Now I would like to open this discussion up for questions. This is your time to go ahead and ask me any questions you'd like. So one of the questions that one of the attendees had is that they wanted to know if our vent strategies for our patients are published. So our strategies and protocols are proprietary and intellectual property of Craig, so they are not published. However, if you go online, there is a wealth of information out there that kind of describes, you know, these strategies. Unfortunately, I can't divulge anything, but there's plenty on the internet if you look. The next question is, which patient population is more difficult to wean, TBI or spinal cord injury? So at Craig, often, if the traumatic brain injury is serious enough, we don't generally take vented patients with brain injuries. They often are weaned by the time they come to Craig, only because in the case of most brain injured patients, if they're on the vent still, they're not able to participate in rehab. Now, with that said, if the brain injury is not incredibly significant, then obviously we take those patients. But I think it goes without saying that weaning someone off a ventilator that has a barely functioning diaphragm by the time they come to Craig is the most challenging part. We have to rebuild that diaphragm and then honestly do an extensive amount of testing to actually be able to determine whether or not someone is capable of coming off the ventilator. If they're not, then we begin to explore whether or not they're candidates for the diaphragmatic pacer. The next question is, how can I get doctors I work with to trust me as a respiratory therapist when I tell them that the patient is not ready to wean or to be extubated? So everything has to be based on fact. So as you put together your case, you're going to want to demonstrate what someone's spontaneous forced vital capacity is, what does their chest x-ray look like? At this point, what's their mentation? You really need to support it with fact and present your case to the physician. The next one is for individuals not requiring ongoing ventilation or trach support. Do you typically recommend exercise programs for maintaining of respiratory strength? If so, what might this entail? So the first thing that you're going to want to discover is how much of that diaphragm is innervated. So what of the respiratory system has been spared by a spinal cord injury? You can't really work out the part of the diaphragm that's no longer functioning because it's not innervated. But you want to strengthen what is left. So that's going to include the respiratory muscles besides the diaphragm. So your neck and shoulder muscles. We do a lot of guppy breathing here. And that actually helps training patients that if they were to ever to accidentally get disconnected from a ventilator, even if they didn't have a functioning diaphragm, they could survive off the vent for a while. If they do have a part of the diaphragm that is still innervated and still functioning, then you can kind of work on strengthening that part. We often use, if you look at, well, I don't know if can I go back to the slides at all?
Yeah.
Okay, so let's see. With all the equipment. So up in the right-hand corner, you see something called the breather. It's an inspiratory and expiratory muscle trainer. This can be set to provide resistance or PEP therapy on inspiration and expiration. Also, our PT and OT department have come up with some really brilliant games that require breath control. Whether it's running their wheelchair on a sip and puff or playing blow darts or even some of our video games that are breath controlled. It's kind of a fun way to help the patients rebuild strength. And remember, it's interval training. So you want to start off slow, like you're training for a race, like a marathon. So the next question is with the diaphragmatic pacer, how many patients a year are leaving Craig? I have personally used this with my late husband, but find not many doctors have had a patient with this, and that's true. So wherever you live, once you receive a diaphragmatic pacer, you're really going to want to investigate your next step. Who is your pulmonologist when you're out in the community? Because you're going to have to do a fair amount of educating with your healthcare providers, even your doctors, on how the diaphragmatic pacer works and how it needs to be maintained. And if your original rehab facility offers what we call reevaluation programs, where you can come back 6 months to a year later for what we call a tune-up, we would highly recommend that you investigate that. So the next question is weaning processes in rehab are more aggressive than in acute hospitals. So does Craig have protocols, or do the respiratory therapists have to contact the doctors for each step? And the answer to that is a little bit of both. So we do have a full set of protocols that we follow if the physician has placed the patient on a respiratory weaning protocol. If it's something a little more interesting or different, then the physician will call the shots step by step. But here at Craig, most of our patients are placed on respiratory weaning protocol, which unfortunately I can't share with you because it's part of Craig's intellectual property. So that concludes our webinar for today. And again, thank you for attending. And I hope you have found this helpful and informative.
Thank you again for attending. If you have any questions, feel free to email Spencer Fortier at sfortier@craighospital.org for any questions regarding the presentation, and be sure to keep a lookout for webinars coming in 2020. Thank you.